Hello guys, hope you're all well. I'm going to take you through a presentation on contraception. These are things we all know, but just a recap on one or two issues. So contraception is a deliberate prevention of conception or impregnation by various methods. Another definition is the use of artificial methods or techniques to prevent pregnancy by interfering with normal process of ovulation and fertilization. So it includes both temporary and permanent methods. So an ideal contraceptive should be safe. It shouldn't do any harm to the patient. It should be very efficient, meaning it should have the minimum failure rate if possible. It should also be acceptable and with minimal side effects. It should be reversible in case someone wants to have a baby again. And it should be fairly affordable and requires little to no medical supervision. So like I said, we have temporary and permanent methods of contraception. These are the examples that we have. So we have barrier methods. Some people opt for natural contraception, the intrauterine device, hormonal methods, and the Plan B. On the permanent, we have the vasectomy for the males and tubal ligation for the females. This is just a diagram a picture showing the different types of contraceptives that people can use. This just shows the organs that are worked on by the various types of contraceptives. So the oral contraceptives usually work on the ovary, preventing ovulation. The IUDs work in the uterus, making it a hostile environment for implantation. And then the barrier methods work in preventing the sperms from passing through the cervix into the uterus. There are certain people who don't want to introduce anything into their bodies, so they prefer natural contraception. So we have different types. So we have total abstinence, which is the only method that is 100% safe for obvious reasons. We also have the withdrawal method, which is also referred to as the coitus interruptus. And then we have lactational amenorrhea, usually when you're exclusively breastfeeding and when menstruation has not yet started postpartum, and it's usually up to 6 months postpartum. Thereafter, you may have a baby whilst using this method. Other methods are based on fertility awareness, like the calendar method, which works for people with regular menses and who track their periods, either using a period tracker or plotting down on a calendar. See which days they'll be fertile and which days they're ovulating. So usually we start the menstrual cycle on day 1 of your menses. And if you have a regular 26 to 28 day cycle, we say ovulation usually happens on day 14. So you count about 3 days or so before ovulation and a day or 2 after ovulation. So you can use the basal body temperature method, where your temperature when you're ovulating, it goes up by 1 or 2 degrees. You can also use the cervical mucus method, where your cervical mucus starts thinning towards ovulation and it's at its thinnest when you're ovulating. So you can gauge using that as well. So this is just a diagram of what I was explaining about the infertile days, the days where you're most fertile, and it's also outlining the percentage of fertility that is there, but it's usually the 5 days, so from the 11th to the 16th day, that's when you will be most fertile. So on barrier methods, we have the male condom and the female condom. We also have the diaphragm and the spermicides. So the male and female condoms are mainly used by anyone really, but by other people who have contraindications to oral contraceptives and IUDs, or they can't tolerate them for whatever reason. They basically prevent sperm from meeting the egg. And then the spermicides, they kill the sperms. They can either come in forms of creams, suppositories, and soluble films. So the advantages of the male and female condom, we have the ease of use. It's also very cheap compared to the other methods of contraception, and it's available without prescription. You can even find it on the supermarkets, and it's also given for free in government facilities. It also protects against STIs, and it doesn't have an age limit for use. I mean, as long as you are above 18 years. The disadvantages are the decreased sensation. Other people can have hypersensitivity reactions since most of them are latex, and other men have issues with disposal and they can be embarrassed to buy the condoms. So the failure rate is about 3 to 18 out of 100 women per year, and it's mainly due to incorrect and inconsistent use, if the condoms are defective, and if there's tearing or bursting of the condoms. The advantages of the female condom is that it's controlled by women. It also prevents STIs, but more effectively than the male condom, as it covers some perineal area as well. There are less allergic reactions because it's made of polyurethane, and there are less chances of tearing. The main disadvantage is some women have difficulties inserting it. Moving on to IUCDs. These are small contraceptive devices. They're usually T-shaped, and they either contain copper or levonorgestrel. And these are inserted into the uterus. So they are one of the forms of long-acting reversible contraception, and they are also the most highly effective types of reversible birth control, with a failure rate of about 0.8%. So you can insert it postpartum during the lactational amenorrhea, or at the time of menstruation, or 2 to 3 days after. So if it's inserted at this particular time, it starts working immediately. The types of IUDs that are there's the non-medicated, which is no longer in use, but it used to be there. And then on the medicated types, we have the copper T and the levonorgestrel, which is the Mirena. And they vary in terms of the time that they can be replaced. Some can be replaced after 3 years, some after 5, and some can last up to 10 years as well. So besides contraception, they also help in the treatment of dysfunctional uterine bleeding, fibroids, endometriosis, and adenomycosis. And their failure rate is about 0.1 to 0.2 out of 100 women during the first year of use. Side effects that you can incur, they can lead to an ovarian cyst, the ones that are hormonal, like the Mirena, weight gain as well, breast tenderness, nausea, and vomiting. So basically, the mode of action is increased tubal motility, which prevents fertilization. There's an endometrial inflammatory response, which decreases sperm transport and hinders the ability of the sperm to fertilize the egg. Then the copper device, ionized copper that's in there, has anti-fertility effects by preventing the blastocyst implantation through enzymatic interference. Copper also initiates the release of cytokines, which are very cytotoxic. The Mirena induces strong and uniform suppression of endometrium, and it makes the cervical mucus become very scanty. It also induces anovulation and insufficient luteal phase activity. Contraindications to the IUD, not everyone can use it, especially people who have had pelvic inflammation, either due to pelvic inflammatory disease or STIs or anything else within the past 3 months or currently. Any undiagnosed genital tract bleeding, if you're suspecting that you're pregnant, people with uterine fibroids, people with congenital uterine malformation, people who have severe dysmenorrhea, if you have a history of ectopic pregnancy, if you have significant immunosuppression, that is those with diabetes, HIV, or cancer, or if you have a copper allergy. Some of the complications that are immediate, someone can collapse soon after insertion. You can have cramp-like pain for the first few hours, up to 24 hours. And if it's not inserted correctly, you can have partial or complete uterine perforation. The long-term complications involve pain, which is lower abdominal, and it normally comes during your menses as dysmenorrhea, or it can just come anytime during the menstrual cycle. You can also have abnormal menstrual bleeding, and it becomes very difficult to track your menses. You can have pelvic infection as well, due to the introduction of the copper. If there was any infection along the genital tract, it can move up to the pelvis. You can have spontaneous expulsion of the device, or it can get displaced, and you can also have an ectopic pregnancy. So you can remove the IUD at any time, but these are some of the indications that you can work with for removal. If someone has persistent uterine bleeding, flaring up of some infections like salpingitis, if you have perforation of the uterus, if the IUD has been partially expelled, if you're pregnant but the device is still in situ, if you're desiring to have another baby, or if you can't locate one of the threads, or when the lifespan of the device is over. These are some of the disadvantages and advantages of the IUD. So the advantages are that it's simple to use. Once it's inserted, then you have to check for the threads every month after your menses, just to check if there's any displacement or if you can still feel the threads. But it's like once a month, and you don't have to go to the hospital to do it unless you can't locate the threads. There's also immediate return of fertility on removal, and there are no systemic side effects for those that are using the copper T, and it's also effective in long term. The side effects are that disadvantages are that it's got side effects and complications just like any other contraception, and it does not prevent HIV or STDs, and you need medical assistance on insertion and removal, and it may come out without your knowledge. The last part of the reversible contraception is hormonal contraception. So these usually contain female hormones, estrogen and progesterone. And you can also have the injectable, which you can have every 3 months. That's the depot. So the combined oral pills, some of them have 21 tablets with 7 placebo tablets containing iron and vitamins, just to complete the cycle. But you can also have the 28-day tablets that you take continuously without the placebo. The commonly used estrogen is ethinyl estradiol, and the commonly used progesterone is noethisterne. So examples are microgynon, and it's usually started any day of the first 5 days of the cycle and taken once a day, usually around the same time, so that the chances of forgetting are slim. So if you take it at any other part of the cycle, which is not the initial 5 days when you're menstruating, you have to use it with a barrier method to prevent pregnancy, because you could be ovulating at the time. So you need to use, it's better to just tell the client either way to just use a barrier method when they start the contraception, just to make sure that they don't get pregnant. So these hormones inhibit ovulation, and they act at the hypothalamic level, inhibiting the release of gonadotropin-releasing hormone. They also suppress the secretion of FSH and LH from the pituitary glands. They alter the maturation of the endometrium, making it unsuitable for implantation. Progesterone also makes the cervical mucus thick and impermeable to sperms. Some other people use the phasic pills, which can be biphasic or triphasic. So they just have different strengths of ethinyl estradiol and levonorgestrel, depending on the days. The mini pill contains only progesterone, and it's used by breastfeeding mothers and also people with sickle cell who avoid the effects of estrogen that is in the combined pill. So the examples that we've got Cerazette, which contains 75 micrograms of desogestrel, which is taken once a day throughout the cycle at the same time each day. So they basically inhibit ovulation, hinder implantation, and make the cervical mucus thick as well. Menstrual irregularities and amenorrhea are common with the use of the mini pill, and some of the side effects include alopecia, loss of libido, weight gain, and nervous irritability. Newer pills on the market, the likes of Mercilon, Marvelon, Yasmin. These they are also combined. They have ethinyl estradiol and a newer progesterone. So you find for Mercilon there's desogestrel, which has minimal androgenic side effects and also reduces the risk of cardiovascular disease. So because of these androgenic effects, they are useful in patients with polycystic ovarian syndrome, acne, hirsutism, and also androgenic alopecia. Contraindications to oral contraceptives are listed below. So we've got thromboembolic disease, acute or chronic liver disease, breast cancer or genital cancer. Obviously, if you're pregnant, you shouldn't be taking the pill. People with high blood pressure and diabetes, people with valvular heart disease, epilepsy, smokers, people with sickle cell anemia and thalassemia, asthma and some allergic disorders, varicose veins, and people who are obese. Side effects are nausea, vomiting. You can have breakthrough bleeding, absence of withdrawal bleeding, which is called the pill amenorrhea. You can develop hypertension or cardiovascular disease, and some people gain weight on the pill. There can be pain and tenderness due to engorgement of breasts, impaired glucose tolerance, and there's also a higher risk of breast and cervical cancer. So the failure rate is about 0.1 to 0.58 per 100 women per year. And it's due to irregular taking, where you miss the pill today or tomorrow, and then you don't do anything about it. People with malabsorption disorders, because if it doesn't get absorbed well, then the efficiency is also reduced. If it's taken along some drugs that are contraindicated, like rifampicin, penicillin, tetracycline, ampicillin, phenytoin, etc., they can reduce the efficacy of the pill, or the pill can reduce the efficacy of these drugs. So what normally happens is you should always take a thorough history and find out if the patient is on any medication that can potentially affect the efficacy of the contraceptive pill. So if you miss a pill for more than 2 consecutive days, the client should use dual contraception for 7 days. But if they forget one pill, they should take it as soon as they remember it, and then the second pill, third and fourth, can be taken as usual. There are other uses of contraceptive pills that is not necessarily contraception. So for people who have irregular menses, you can use it to regularize your cycles. You can also use it for people with dysfunctional uterine bleeding probably due to hormonal imbalance, because that can balance the hormones. People with endometriosis, so these can take continuously for 6 to 9 months, and not in a cyclical manner, so they don't have to take the placebo pills, they just take in continuation. You can also use it to postpone your period and for suppression of functional ovarian cysts. Then we move on to the last part of the pill, which is the Plan B. So this is an emergency measure to prevent pregnancy following an unprotected but possibly fertile intercourse, of which we regard every intercourse as fertile. So whether they are on the infertile days or not, according to their calendar, is just best to take a pill, because you never know, really. So the indications are failure of a barrier method in case a condom bursts, or in case it bursts. If you have unsuccessful coitus interruptus, if you miss a pill, or for those cases that involve sexual assault. So we use the progesterone-only pill as one of them. Levonorgestrel 0.75 milligrams. So if you use the 0.75 one, you have to give it in 2 doses, which are 12 hours apart. Or you can just give the 1.5 milligram as a start dose. So the first dose should be started as early as possible, because the efficacy reduces as the hours progress. You can also use the IUCD. So insertion of the IUCD within 5 days of intercourse can be used as a Plan B. The reported failure rate is 0 to 1%. Anti-progesterone medications can also be used, where you can use mifepristone 600 milligrams as a single dose within 72 hours of unprotected intercourse. Recent studies have shown that even the lowest doses, like 50 or 10, have also found to be effective. But it's better to just stick to the 600. So now we're moving on to the permanent contraceptives, where we have the female and male sterilization. So female sterilization is also known as tubal ligation or tubectomy, and it's a surgical procedure where the fallopian tubes are severed and sealed or pinched shut. So this prevents the eggs from reaching the uterus for implantation. It is a highly effective, safe, and simple procedure that involves cutting, tying, or removing a part of the fallopian tubes. So there's a selection of candidacy for sterilization that can be used, but generally with proper counseling and informed consent, any woman can have this procedure done safely, including women who have no children or have a few, people who are not married, people who are young, but above 18 years, of course, people who have just given birth within the last 7 days, and also people who are breastfeeding. The advantages are that it's very effective, and it gives permanent or lifelong protection. After you have the procedure, there are no repeated clinic visits that are required when you're fully healed. It doesn't interfere with sexual intercourse, so there are no issues with loss of libido and all this preparation that you need to do with some contraceptives. And there are no known long-term side effects or health risks. The disadvantages are that you have pain for a few days after surgery. You can have infection or bleeding at the incision site. You can have abdominal pain, perforation of the fallopian tube. You can have an ectopic pregnancy or reaction to anesthetic drug, and also delayed recovery. So for the males, vasectomy is a surgical procedure that is used for male sterilization, and it's a method of permanent birth control. So during the procedure, the vas deferens of men are tied and separated to prevent sperms from entering into the seminal stream. Pregnancy may occur after vasectomy because of failure to use another birth control method until the sperm count is confirmed to be 0. So after vasectomy, you need to have 2 different semen analysis at different times just to make sure that your sperm count has reached 0. And it normally takes about 10 to 20 ejaculations to completely clear sperm from the semen. So this is just a diagram showing where exactly is cut. So you can see the vast difference there. It's cut and tied from both ends, and then they seal the ends as well. So we can have complications of the procedure. There can be bleeding under the skin. You can have infection at the site of the incision. Sperm can leak from a vas deferens into the tissue around it, and then a granuloma can form. You can have epididymitis, and in rare cases, recanalization can occur where the vas deferens joins back naturally and the man becomes fertile again after many years. The end.